So Dr. Filipe Cirne received his medical degree and core cardiology training from Brazil. He also holds a master's degree in cardiovascular sciences, also from Brazil. And this was followed by advanced echo and cardio-onc fellowship at McMaster University. He is an assistant professor now in the Department of Medicine, McMaster University, and a staff cardiologist at Hamilton Health Science. His main interests are echo, with special interest in structural heart interventions and cardio-oncology. So we look forward to hearing your presentation. Please go ahead.
Good morning, everyone. I hope you can see my slides and you can hear me well. If not, please let me know. It's a pleasure to be here. Thank you for all the ones involved in this. And as I mentioned before, I'm already a fan of this of the virtual backgrounds you have, and I follow you on your YouTube channel. I really like the lectures. So today we're going to talk about the use of echo in the cardio-oncology scenario. I should say it was a little bit challenging for me to put this together because we don't have many specific things on echo that are essentially only used in cardio-oncology. So most of the things we do in cardio-oncology, we also do for the general population of patients. There was, as you know, historically this hype with strain, but strain use is widespread across all subspecialties, let's say. And I'll actually talk a little bit less about strain today because I feel like there is some fatigue already on that when we talk about echo and cardio-oncology. But essentially, the learning objectives are talking a little bit about monitoring of cardiotoxicity, which echo is one of the main, let's say, parameters we look at. Use of contemporary echocardiographic techniques in cardio-oncology, how that applies and why I think those are very important. And the echocardiographic assessment of cardiac tumors, which is probably the scenario in which when applied to cardio-oncology, meaning malignant masses, I think echo might make the main difference for this population. So I'll start with the case. So this is a 50-year-old female with HER2-positive breast cancer. So she is status dose-dense ACT, which means anthracycline and paclitaxel. She received a cumulative dose of 240 milligrams per square meter of body surface of anthracycline, doxorubicin, and then she's also status post bilateral mastectomy, and she's currently on trastuzumab. So this is her baseline echo with an EF of roughly around 60%, no major regional motion anomalies. This was an overall normal scan. You can see, though, that while image is not terrible, it could be better. Maybe they could have used contrast to delineate whole endocardium more precisely. This patient has history of bilateral mastectomy, which sometimes can make it more difficult. Sometimes these patients have breast prosthesis post-surgery, which might make it even more difficult. Radiation to the chest. Those are all things that can make scans more complicated and imaging more technically challenging in this population. And then this is the echo 5 months into HER2 therapy. So you can see that there is clearly a reduction or a drop in the left ventricular ejection fraction. So this was reported as 45 to 50%. I think the specific number they used was 48%. You could argue again, maybe they should have used contrast. Maybe the two chamber is a little bit foreshortened, which is something we should always try and avoid. And maybe even on the two chamber, they could have opened it a little bit better because on the left, you can see maybe a little bit of the septum still. So those are all things that, especially for this population, which sometimes some small changes in the left ventricular function might change the whole treatment and the whole management strategy. We need to be very, very careful about all those things, and I'll touch more on that later. So as per the guidelines, echo is recommended as the first line modality for the assessment of cardiac function in patients with cancer, the class 1 recommendation. We know that the level of evidence is C, but echo is such an easy tool and accessible and cheap that it makes sense. And I wouldn't, for example, recommend cardiac MRI for all patients. That would be great in an ideal world, but we know that that's not feasible. So we save that for challenging studies or whenever that we have echocardiographic findings that need confirmation. And then baseline comprehensive TTE is recommended in all patients with cancer high risk and very high risk of cardiovascular toxicity before starting anti-cancer therapy with the same class of recommendation and level of evidence. As a caveat, I do want to mention that if you go into the cardio-oncology guidelines, you will see that the level of evidence for most of the recommendations there is weak. This is a relatively new subspecialty, you could say. So we still need lots of studies, which might actually include even timing of echo for these patients. We do that mostly based on studies that tested the drugs and what would be the recommendation during that protocol, but we don't really have trials saying, okay, in patients with trastuzumab, actually doing echoes every 3 months while on therapy is better than doing every 6 months or yearly. We don't really know that. Ideally, we will have that data at some point, but essentially, that's what we have and that's what we do in clinical practice. So these guidelines, very much they focus on a baseline risk assessment, which I think makes sense. Again, limited evidence to say that that's better than any other approach, but that's what is being recommended out there. So you will do a baseline cardiovascular risk stratification. They even recommend this risk score from the International Cardio-Oncology Society, and based on that, you will deem if this patient is low risk, moderate risk, or very high risk for cardiotoxicity, and that include all the cardiotoxicities, not necessarily only LV dysfunction and heart failure. So based on that, you will have some guidance on what to order, meaning all these patients need ECGs, do all these patients need echoes, do all these patients need biomarkers like NP, proBNP, or troponin, and how often will we do that later on while on therapy and also after therapy. And as you can see here, there are many cancer therapies that can actually be associated with specifically here LV dysfunction and clinical heart failure. Now, when we talk about LV dysfunction in this setting, so there are the symptomatic patients, which are obviously more concerning, and most of the times these patients will require that they hold therapy, and maybe this will never be reintroduced. They'll have to find alternative therapies, or these patients will be moved into a palliative approach, which is oftentimes very sad, but it's just that, as you know, the risk of developing clinical heart failure, and especially if there is further decline in EF, that portends a prognosis that can be sometimes just as bad as advanced cancer. So, of course, we don't want to cause more trouble than what's already happening in this patient's journey. And then what we see more commonly, though, is asymptomatic chemotherapy-related cardiac dysfunction. So there are a couple classifications or definitions out there. In this guidance, they even stratified into mild, moderate, or severe. What we see more commonly, again, is the moderate one, in which you require, for you to be in that category, you require at least 10 percent points on the LVEF to an absolute number of less than 50%. If that number is less than 40%, then it's classified as actually severe dysfunction. And or alternatively, and that's where strain has its use according to the guidelines, but again, limited evidence, which I'll touch on that later. So if the drop is less than 10%, but still to below 50% absolute number, you can use strain as an adjunct tool. And if there is a relative reduction of more than 15% on the strain from baseline, you could argue that this patient also has moderate LV dysfunction. Now, I'll start with the trastuzumab, which I think is probably the scenario in which we as echocardiographers are more heavily involved on the screening, surveillance, and why not even survivorship, you could argue. So this was the main trial, or at least one of the first trials, to show that trastuzumab in patients with breast cancer who are positive for the HER2 receptor, which is roughly 30% of the patients. So these patients benefit from receiving this drug that is actually considered immune therapy because it's a monoclonal antibody. And it was shown that using this drug on top of what was already the standard of treatment at the time improves survival free of disease, improves survival free of metastatic disease. And but it also shows that the regimen, the ideal regimen, should be 1 year, because using 2 years of trastuzumab doesn't add to prognosis and disease-free survival, but it adds in terms of it increases risk of toxicity. So in this trial specifically, there was a 7% incidence of LV dysfunction, almost 2% incidence of symptomatic heart failure, and 0.5% incidence of severe heart failure, which is essentially NYHA class 3 to 4 symptoms. There were studies later on showing different incidences of LV dysfunction heart failure in this population, but roughly we know that this is around 10%. So whenever that you have someone receiving trastuzumab, there is 1 every 10 patients will have LV dysfunction, which is most of the times asymptomatic. And then for clinical heart failure, symptomatic heart failure, that number is roughly around 2 to 4% nowadays, based on meta-analysis published after a couple of these trials. And then just to show that it's not negligible, at least at the time it was not, the proportion of patients that would be required to stop trastuzumab, usually during the second and the third quarter. Of course, the practice evolved. Now we have this so-called permissive cardiotoxicity concept that we apply more often than not, because we know most of the times, unless the patients develop symptomatic heart failure or severe chemotherapy-related cardiac dysfunction, it's most of the time safe to continue with these agents, provided that you follow them closely and you use GDMT, of course. And then one might ask, okay, but why does it matter? Is it really important if patients receive 6 months of trastuzumab or they complete the full year? Well, apparently it is, because this meta-analysis showed that the overall survival is significantly reduced in patients who can't complete 1 year of trastuzumab. So in terms of echo surveillance, as you know, these patients will receive a baseline echo for sure, and then it will go for echo every 3 months while on therapy. Those deemed to be at high and very high risk on these guidelines, they recommend that these patients get an echo done at 3 months post completion of therapy, and then 12 months. And then after that, we don't know. The overall recommendation for patients who have received potentially cardiotoxic therapies, meaning LV dysfunction, in this case in heart failure, they repeat echoes roughly every 5 years or so. So you can consider doing that. And of course, keep in mind that this mostly applies to the non-metastatic population, because patients with HER2 positive breast cancer that are metastatic, they might require these therapies for life. Now, as I mentioned before, the evidence on the ideal interval for echoes here is quite limited, and I should say it's even more scarce in the metastatic population. We do apply this to the metastatic population, but we don't really know. Because the thing is, if they stop their therapies, their prognosis is even more compromised than if compared to the non-metastatic population. Now, just switching quickly to the anthracycline, which is how I would say cardio-oncology started as a subspecialty. As you all probably know, so this is a cumulative dose effect, and also it's usually reversible. So those are the two main differences of LV dysfunction caused by anthracycline if compared to trastuzumab. Of course, there will be the outliers that will escape that rule, but most of the times this holds true. So you can see that once we reach a cumulative dose of 240 to 150, that's when things start to get really concerning, and that's when the risk of cardiotoxicity starts to increase exponentially. So nowadays, most of the times, whenever possible, the oncologist will work towards aiming a maximum cumulative dose of 240 to 150. So what are the risk factors here? Well, cumulative dose, as I mentioned, extremes of age, female gender, mediastinal radiation is an important one, presence of baseline risk factors, and also presence of baseline structural heart disease. And so as you can see, echo is an integral part of this assessment. And then, of course, use of other concomitant cardiotoxic agents. So whenever that we have patients using trastuzumab and anthracycline, whether as concomitantly or as a sequence of events, that risk increases further, and that very much applies to the breast cancer population. So during active treatment, anthracycline-induced cardiotoxicity is quite rare. Within 1 year, it's uncommon, I would say, and most of the times, whenever that we see this, it'll happen or it'll be noticed after 1 year, at least 1 year after completing therapy. And here, the incidence of clinical or overt heart failure is around 5%. So the surveillance here, I would say, in terms of evidence, we have probably even less guidance than trastuzumab, unfortunately. But essentially, you will require baseline echo. For the most part, you will need an echo 1 month after completion of therapy. Now, this guidelines say that in patients who are high risk, you can repeat echo after second, fourth, and sixth cycle while on therapy, and then 3 months post-therapy. And then after that, in terms of survivorship, based on the risk profile, you'll repeat echoes every 2 to 5 years. So different agents will have different cumulative doses at which the risk of cardiotoxicity increases. So as an example, idarubicin requires a lower dose, a lower cumulative dose if compared to doxorubicin to increase the risk of cardiotoxicity, whereas daunorubicin requires a higher doses. So whenever that they're using agents other than doxorubicin, remember to use this table, which is widespread on the internet, to check the isoequivalent dose, especially if you're following those the cardio-oncology guidelines to estimate the risk of heart toxicity and how you're going to do your surveillance after that. So let's go with another case. So this was a 42-year-old male with stage 4 adenocarcinoma of the rectum who developed acute onset chest pain 3 hours post first dose of palliative 5-FU, so which would automatically make you concerned about coronary spasm. This is his initial ECG. You could argue maybe hyperacute T waves. I don't see any other major findings here. Then this is his angiogram. He was pain-free when he had his angiogram done. He had already been managed for the chest pain in the ED, so it's a normal one, as you can see. And then this is his echo. So the basal segments appear to be working more or less okay, but everything else is down. Now, he was treated with GDMT for that. He had his cancer therapy stopped, unfortunately, because of that. So his initial LVEF went from 25% to 55 to 60% on the follow-up. And this is just to bring to your attention that other therapies can be associated with LV dysfunction. So tyrosine kinase inhibitors, most commonly VEGF inhibitors, like cabozantinib is an example, or osimertinib, which is an EGFR agent, are also associated with LV dysfunction. Proteasome inhibitors, which are more commonly used for patients with multiple myeloma, alkylating agents like cyclophosphamide, which is also a dose-dependent effect, BCR, ABL inhibitors, RAF and MEK inhibitors, which are newer agents, I should say. 5-FU, as the case I showed to you, usually in the setting of coronary spasm, so most of the times transient. In the setting of ICI myocarditis, which is something that we are seeing more often nowadays. That being said, there are some studies showing that in the presence of ICI myocarditis, 50% of the patients will have a normal echo. So in these cases, you usually, I would say, not usually even, always you need at least a cardiac MRI for further assessment, and oftentimes they will end up requiring myocardial biopsy. And then even radiotherapy can cause direct damage to myocardium, scarring, and even LV dysfunction. Okay, now talking a little bit about what I consider to be some more contemporary techniques in echo. So the use of ultrasound enhancing agents is widespread, as you know. But why do we do that? And why do I think it's important in cardio-oncology? Well, as you can see, so they decrease the number of interpretable studies from roughly 12% to less than 0.5%, which is quite remarkable. They also are shown to decrease the number of technically difficult studies from roughly 90% to 10%, reduction of unnecessary downstream testing by up to 33% on some studies, change in management in up to 35 to 40% of patients. Some studies even show reduction in length of stay, and it improves concordance between echo and cardiac MRI, which is the gold standard for assessment of LV volumes and ejection fraction, as you know, and that is if in comparison with non-enhanced scans. Now, just briefly touching on strain, I'm not going to spend too much time on this. I know people are already well-versed on this. So this is an early marker of toxicity, and that's how the whole story of strain in cardio-oncology started. So the cutoff historically is a relative reduction of 15%. There are many studies showing that it has a higher reproducibility and sensitivity if compared to LV ejection fraction, biplane method, I should say. The technique used nowadays is speckle tracking. In the old days, it was based on tissue Doppler. Now, at normal heart rates, so we should aim for a frame rate of 40 to 90 per second, ideally. So there are a lot of, let's say, technicalities on strain and requirements for you to check before you can say that actually your strain assessment is accurate and reproducible. So we should always keep that in mind. More contemporary studies, they actually challenged the usefulness of echo-derived strain for cardiotoxicity monitoring. The one that I have in mind that was published recently is actually from Toronto. It was published led by Dinesh. It's a Sukur trial. I'm sure everybody or almost everybody heard about that study. So essentially, they tested whether a strategy of cardiotoxicity monitoring by strain or LVEF would be more, let's say, accurate for changes in the LV function. For the primary outcome, the study was negative. For some other secondary outcomes, the study was positive. So there is a debate there whether this was actually maybe a positive study and whatnot. And this was actually followed by a cardiac MRI strain-based study that was positive. So that puts us the question. But I think this was an important landmark because it really tested strain in that setting. And then I think it had put it to the test because the primary outcome was negative, as I mentioned. And then there are some studies now showing that 3D strain actually is better, more reproducible, and more accurate than 2D strain. This is not widespread in clinical use, I don't think. It's mostly a research topic yet, so it requires further studies and validation. It can be quite cumbersome to actually do that in a busy lab and it requires specific software. So maybe we'll be seeing that more often in the future if this is streamlined, but I don't think this is the reality nowadays, unfortunately. And then the advantages of strain. So it uses grayscale images obtained on routine echo. It's quite fast nowadays. It has good signal to noise ratio, minimal angle dependence, ability to measure strain in multiple LV segments from a single acquisition. That's very nice. High reproducibility, as I mentioned before. And I think the nicest thing is that these automated post-processing softwares, they do streamline the measurements, and they actually nowadays require minimal user input. You might still have to make some adjustments here and there, but most of the time the software is pretty good for that. And then in terms of limitations, so the accuracy depends on 2D image quality, as you know, of course. Another benefit I should mention is that it's less load dependent on LVEF. Sorry. And then another limitation is the inability to track speckles moving out of scan plane of the 2D image. So you need to make sure you optimize your 2D image quality. You might have to increase the sector size to make sure you see the whole myocardium on systole and diastole. That being said, as you know, that might reduce the frame rate. So that's a bit tricky. Something that needs to be balanced out. Reproducibility or reliability of segmental strain values are not established, not validated. And in terms of vendor-specific strain techniques, because they vary a lot, so there is variability in strain measurements and cutoffs used. For example, if you use a Samsung machine or you use a GE machine. I think Philips and GE are getting pretty close with that, and thankfully, those are the main brands used nowadays, so that makes things easier. But I do know that some other smaller labs might use other machines. And then data that's stored in proprietary scan line format is not analyzable using another vendor software. So essentially meaning that if your strain was acquired with the GE machine, you're not going to be able to reassess that on a Philips machine or on a Philips application. And then lastly, here I wanted to talk a little bit about 3D LV ejection fraction. So in terms of assessment of LV dysfunction on echo, this is the method that has the highest reproducibility, and it has the lowest inter and intra-observer variability, as well as the lowest time-related variability. So this is another study published by Dinesh from Toronto, and essentially they compared assessment of LV volumes and EF by biplane method with and without contrast, triplane method with and without contrast, and 3D with and without contrast. And they show that essentially, number one, use of 3D had the lowest time variability and the highest reproducibility. So this is a baseline population of patients on cancer chemotherapy with potential for cardiotoxicity who are deemed to have stable LV function over time based on GLS. That's the comparator they used, let's say. And then in this study, they also showed that 3D LVEF without the use of contrast had the lowest intra and inter-observer variability, and also the lowest inter-observer test-retest index. So to end the talk on LV dysfunction here, so keep in mind that small errors can have big impact not only on the number you're seeing on your screen, but also on management and this patient's journey. It can be quite, let's say, bad, and it can impact the prognosis a lot if someone is on trastuzumab half the way in the 1-year course, and then they have to stop therapy all at once. And same holds true for anthracycline, but I would say it's more striking with trastuzumab because we see that earlier than with what we see when we see LV dysfunction with anthracyclines, and even some other therapies like osimertinib VEGF inhibitors. I had a couple patients that had to stop therapy because of LV dysfunction and or clinical heart failure, and then of course their prognosis is badly impacted. We should make due diligence with foreshortening and making sure proper 4-chamber, 2-chamber, and 3-chamber views are acquired. This is a general rule in echo, doesn't only apply to cardio-oncology. As you know, if needed, be adjust gains, compression, depth, sector size. Be liberal with ultrasound enhancing agents. If unsure, use it. If you can see one segment of myocardium, I would argue that you can already make the case for using contrast. And then another very important thing is to communicate with your echo techs and repeat images as needed. Bring patients back to your lab as needed. If initial scan was done without contrast, and if you feel like you need it, bring patient back. If 3D LVF was not attempted on the first scan, you're bringing the patient back. Try that again. These are tools that are more easily available nowadays, so I think we should take advantage of that as much as possible. And then, of course, you can use complementary imaging if echo is technically limited or is not answering the question that's questioned. You can use, for example, cardiac MRI, which, as I mentioned before, is the gold standard for LVEF and LV volumes. And this is particularly helpful in patients who are, for example, have breast implants, which can make echo imaging quite challenging, and also patients who have had thoracic or mediastinal surgeries, which is not uncommon in the cancer population, as you know. After that, this is more of a personal opinion, I should say. I feel as if even though your baseline echo images are maybe not as good or are limited, if you do a cardiac MRI and the LVEF correlates well, I think you can probably safely use echo for surveillance after that, because I feel as if feasibility of doing cardiac MRIs every 3 months, at least in our center, I mean, that would create problems. Let me put it this way. It would be challenging. I'm not saying impossible, but challenging. And then, of course, I'm not sure that is sustainable. It would be sustainable to start doing that on a regular basis for every patient that has a technically limited echo in this scenario. This is another case of a 36-year-old male who was followed at the Cardio-Oncology clinic due to repetitive episodes of non-sustained VT, which is deemed to be secondary to myocardial scarring from prior anthracycline chemotherapy for large B-cell lymphoma. This patient also has a prior history of PE. And then on his surveillance echoes every 2 years they were doing this, there was a new finding that you can see there. Focusing on the right atrium, they can see this hyper-echogenic image inside the right atrium, and they were not sure what it is, so the oncologist referred the patient to us. It was thought initially that maybe this was residual thrombus or casting from maybe a catheter or the thrombus that was there, or a thrombus in the setting of the prior PE, but this was totally new from an echo done 2 years ago. Interestingly, the patient was completely asymptomatic. So they used contrast here to try and delineate this better. And as you can see, it's seemingly close to the lateral wall of the right atrium, and it's seemingly an avascular structure. So that's why I think also contrast helps for cardiac masses, essentially, because you can tell if it's an avascular structure, which would suggest thrombus, or if you do see some enhancement, that might suggest a tumor, for example. This is a closer look at it, so it doesn't seem as if it enhances significantly. So this was thought to be a thrombus. The patient went for a cardiac MRI. Cardiac MRI didn't commit to the diagnosis, but it suggested, as it possibly being a thrombus. So the patient was anticoagulated, and then 3 months, on the 3 months repeat echo, this was gone. So this was a thrombus, confirmed to be a thrombus. So whenever we are evaluating cardiac masses by echo, I think it's important that we use a stepwise approach. We go from the more common and likely findings or diagnostics to the less common ones. So I think it's important to exercise that. More common things being common, I think the first thing you want to rule out is that making sure that that's not just an artifact, and that will avoid, of course, lots of anxiety, further down unnecessary testing down the line, TE, cardiac MRI, sometimes even cardiac surgery. Secondly, make sure this is just not an anatomical variant. There are so many in echo that we see on a daily basis. Making sure this is not a device. Cancer patients commonly have catheters, and then they might also have pacemakers, ICD, just like the general population. Keep that in mind. They might have prosthetic material as well. Thrombus, another common intracardiac mass in cancer patients. Vegetation, less common, but we do see patients with cancer and endocarditis, of course, just like the general population. And then in terms of tumors, the most common thing being metastatic cancer, and then secondly, benign tumor, and then primary cancer, way less common. And then, of course, you might have to go back and forth depending on your findings and on complementary imaging you might require. So this is to show an example of a patient who was on ibrutinib and developed AFib, rapid AFib. Plan was to go for cardioversion, had his TEE done. While on TEE, they saw this image on the left atrial appendage, but this is clearly an artifact. I don't have the other views, but this was not seen on the views. They also used biplane imaging, and this was shown not to be a real thrombus, but rather a reverberation artifact from a prominent Coumadin ridge, as you can see there. So there are a couple of artifacts that are important that you're familiarized with on echo. Most common ones being reverberation, attenuation or shadowing from calcified structures, mirror image, and side lobe. How to rule in and out an artifact on echo. So a couple maneuvers that we can do, and so change proposition as much as possible. If you see something on one view and you don't see on others, that's more likely an artifact. Ensure image again is seen more than one view. Adjust settings, harmonic frequency, gain, depth. You can zoom on images to have a better sense of what you're looking at. Use color Doppler, use contrast. On the right side, you can use agitated and saline to delineate structures. You can also use ultrasound enhancing agents to delineate better, especially left-sided structures, but also to check the vascularity of that structure, because that might help you, in terms of probability at least, decide whether that's more likely a thrombus or a calcified structure, or if that's really a tumor. And then oftentimes complementary imaging can be helpful or are necessary, even with TE, cardiac MRI, cardiac CT, and even cardiac PET nowadays, especially if you're suspecting of metastatic lesions to the heart. This is another example of a patient that had a TTE done, and then this patient had lymphoma in the past, and then they saw this at the level of the aortic arch, and even on biplane imaging, they could see that. So they thought this must be real. So we need to get an urgent CT or MRI done to check what it is and see what, and check and decide whether this patient is surgery. Or do we need to restage this patient? Is this a recurrence of his cancer? Patient had a cardiac CT and nothing was seen. So this is another artifact. So keeping, again, complementary testing might be required in this population. So this is another nice and interesting echo. I'm sure you guys see this or recognize this more often nowadays. So this patient had a history of renal cell carcinoma, went for his echo, and then they saw this at the level of intraocular septum, AV septum, you could argue there. But that's really just a REC sign, meaning retroaortic coronary. This patient had a coronary CT done, which confirmed that finding. So this is just a normal, not normal, but an anatomical variant, meaning this is not a pathologic finding and nothing needed to be done. No further testing, no further procedures for that. So this is in this picture. I'm just showing you the most common anatomical variants that we might see on echoes. So for the RV, motor band, which can be quite prominent at times, trabeculations, papillary muscles. In the RA, which is probably the most common anatomical chamber to have these anatomical variations, with Chiari network, Eustachian valve, Gustus terminalis, and Thebesian valves being the most common ones. In the intraocular septum, you can have lipomatous hypertrophy or an aneurysmal septum. And then on the LV, false tendon or chordae, focal hypertrophy, papillary muscles, which can be hypertrophied at times as well, prominent trabeculations, which most of the times don't represent non-compacted myocardium. And then in the LA, prominent pectinate muscle, Coumadin ridge, and sometimes even the transverse sinus. This is another patient who was being investigated for a mediastinal mass. So you can actually see the mass there at the top. And then they also saw this other structure just to the right and below the ascending aorta, and here seen below the pulmonic valve. So they thought that because this patient has cancer, maybe this patient now has a thrombus in the pulmonary artery, so he's at high risk for PE. I reviewed the echo, and then I don't know, it looked weird, the location to me. I thought that at first maybe it's an artifact, but the other possibility on that spot would be maybe a left atrial appendage thrombus, and then I suggested they do a TE, and this was confirmed. The other thing is when we have, especially patients with severe LV dysfunction or regional involvement maladies that involve the apex, and this is a general rule in echo, while it's nice to use contrast, as I said, I think we should have a low threshold for using contrast whenever we are unsure. But there are other things we can do to actually reveal structures that are not well seen on the biplane images, and one of them is doing a sweep. So most of the labs, at least the accredited labs, they do that on a routine basis, and our techs are pretty good at that. So that is important because sometimes, as in this case, you can reveal apical thrombus just by doing that sweep. So this was a patient with ICI myocarditis. And then in terms of tumors or masses, if you will, overall, so the right-sided chambers are more likely to be to essentially have malignant masses, while that can happen in the left-sided structures and in the pericardium. As an example, mesothelioma, it's more common on the right-sided chambers, with sarcoma and angiosarcomas being the most common malignant lesions there. So cardiac metastases are 22 to 132 times more common than primary tumors. Most common sources for metastasis to the heart are lung, lymphoma, renal cell carcinoma, hepatocarcinoma through direct invasion, melanoma. There are some autopsy studies showing that up to 50 to 60% of patients with melanoma will have cardiac metastases that most of the times are asymptomatic. And then breast cancer can also metastasize to the heart. But 90% of primary tumors of the heart thankfully, are benign. Now, different modalities here in thinking on a multimodality framework. So different tests will have its pros and cons and its applicability, especially because we're talking about echo. I'll focus on that. And so I think echo is usually the initial imaging modality. TE can be considered, especially in cases of small and mobile masses. As a caveat, in that scenario, it's usually actually better than cardiac MRI and cardiac CT. So the pros of echo are its large scale availability, low cost, repeatability, and then cons, limited tissue characterization. That's when cardiac MRI makes a win, and then limited accuracy in case of poor acoustic window, and that's when we need these other complementary modalities. And then whenever that you see a mass on echo, what would you be looking for? So its localization, anatomical variance, ensure it's not an artifact, check size and morphology, check for appearance of invasion, associated pericardial effusion, and the hemodynamic impact of the mass. Sometimes these masses can be obstructive and patients can have syncope, for example. So tips and tricks. Cardiac masses dimensions might not be related to histology. Recognize normal anatomical variants, as I mentioned before. LV dimension function may suggest an apical thrombus if reduced. Contrast enhanced echo aids to distinguish vascular tumors from thrombi. And there's this score that is not, I don't think it's used commonly, but a score that the EM score of at least 5 is suggestive of malignancy. We don't particularly use that in our lab, I should say. And then some red flags for malignancy in cardiac masses using echo. So if it's right-sided, that raises the flag. If it's sessile instead of being pedunculated, and if there is associated pericardial effusion, you should think more of a malignant mass in those cases. And then sometimes even incidentalomas seen on echo can aid in the diagnosis of new cancer. So for example, a pleural effusion or ascites that's seen on echo. Sometimes we might see a mediastinal mass. Sometimes we might see masses on the liver, tumors invading the heart through the IVC, for example, renal cell carcinoma. And then sometimes we might even see a lung tumor invading the heart through pulmonary veins. And then other common scenarios, just like the general population, they can have other cardiovascular diseases. So CAD, non-ischemic cardiomyopathy, stress cardiomyopathy, valvular heart disease, congenital heart disease. Radiotherapy can be associated with lots of these let's say, necessarily cancer-related diseases, you could argue. So radiotherapy patients do require echo surveillance in their survivorship journey most of the times. Another common use of echo and echo labs in the setting of cancer patients is in the assessment of pericardial effusion, which can be malignant or not. And then echo-guided pericardiocentesis is another, let's say, common request for echocardiographers being involved in the care of these patients. And then lastly, AL amyloidosis, of course, is another disease that is considered malignant. And then nowadays, or at least is treated as such, and echo plays a pivotal role in the management and assessment of these patients. And that's pretty much it. Thank you for your time.